Oral anticoagulation is absolutely essential for high-risk patients in order to reduce the risk of stroke if they have non-valvular atrial fibrillation. But, and this is a huge but, trying to get them to take their medicine as they are supposed to and continuously is really tough. So we are talking about continuous use of a variety of different drugs. Treatment persistence and discontinuation with rivaroxaban, dabigatran, and warfarin for stroke prevention in patients with non-valvular atrial fibrillation. So to talk about this, I'm with Dr. Craig Coleman, who is a PharmD, professor of pharmacy practice at the University of Connecticut in Stores. And this has really been a question. We've got a lot of patients who are on these drugs. They don't work if you don't take them.
Absolutely.
So what did you do and why did you study this first before you get into the study itself?
So I think you said it very well in your introduction. The reason this is so important is these patients with non-valvular atrial fibrillation are at very high risk of having strokes. And strokes are really bad. They're associated with a lot of disability and a lot of cost to the U.S. healthcare system. And so it's incredibly important that we try to prevent these strokes. And anticoagulation is the key in patients with non-valvular atrial fibrillation. But again, anticoagulation only works when the patients are actually taking their medications.
And we have a variety of different choices. Nobody has actually done a study like this before, have they?
No, so this is the first time that two novel oral anticoagulants, so in this case rivaroxaban and dabigatran, have actually been compared in terms of persistency and discontinuation rates, along with warfarin, again, which is kind of the old school classic agent that people have used for many, many years. And so the real take-home message that we were able to demonstrate is that rivaroxaban was associated with better persistency. So patients were more likely to continue to take the rivaroxaban as compared to either dabigatran or warfarin.
What was the difference in terms of numbers? Was it sizable? I mean, obviously it was statistically significant. Was it clinically significant?
So in addition to being statistically significant, the difference was, in fact, fairly large. So we're looking at an order of magnitude about a 35% reduction in the likelihood of continuing to take your medication with dabigatran or with warfarin as compared with rivaroxaban. And I would say that's pretty clinically significant.
Now, it's not only important to get them on the medication and to stay on the medication, but it's important to figure out which patient should get the medication. And we see time and time again that high-risk patients are often not receiving the medication. Low-risk patients, some who don't even really qualify by the guidelines for the therapy, how does that enter into this picture? Now that we know that there is a drug that patients will stay on, will this help any?
Well, I certainly hope so. So our study actually looked at patients who are at high risk for stroke, and that's by a CHA2DS2-VASc score of it being greater than 2. And again, what it was able to demonstrate is that with a drug, a QD drug like rivaroxaban, these patients were able to maintain or stay on therapy for longer periods of time than patients taking the other two anticoagulants. And this was after following patients for about 1.5 years or 2 years on average. So it's why exactly one agent is better than the other, whether rivaroxaban because it's a QD drug, whether it's because there's some tolerability issues with an agent like dabigatran, which often causes dyspepsia or GI upset, whether that's causing the differences in persistence, it's not really clear. But what it is clear is that patients receiving rivaroxaban, again, do seem to be staying on their medications longer than the alternative agents. And if they're staying on their medications longer, then they're far less likely, to have an ischemic stroke.
So what else are you doing? What's next? Anything?
Well, there's a couple of potential research areas that we'd like to further delve into. One of them is trying to figure out, as we just talked about, what is it that makes these medications different? So is it, for example, the QD versus the BID dosing? Is it the side effect profiles of the drugs that are driving them to be different? Because that would help clinicians make better decisions. We already know that, for instance, when we talk about adherence, which is related to persistence, but is talking more about the day-to-day taking of the medication, that QD drugs tend to be more adhered to than twice-daily drugs. You know, whether this really holds true for persistency in long-term use is not as well known. This data may support that idea, but again, we really haven't, robustly investigated that.
Well, thank you very much, because this is an important topic, and we've been covering it for some time, and trying to get people on the drugs correctly is one big thing, but then trying to keep them on the drug, it's really important. So I appreciate your time. And we have a variety of coverage from this AHA meeting, so please check it out for CardioSource World News, where I'm Executive Editor Rick McGuire.